questions on your test that come out of this chapter. Okay, there's going to be 55 multiple choice questions and a couple of case studies. So that should tell you the importance that I'm putting on the chemical exam and the microscopic exam. I'm only picking about 5 or 6 questions out of this chapter. And I'm going to tell you right now which ones I think are important, which sections of this chapter that are very important. So on page 148 under glomerular disorders. So if I say the word glomerular, what am I talking about? What am I even talking about? The kidney, and what's the glomerulus? Nephrons, right? So we're talking about disorders that affect the glomerulus, the little sponge that I wrote on the board that things kind of sift through based on their size, their electric neutrality, and all of that. Okay. So the very first sentence there under glomerular disorders on page 148 says that most glomerular disorders result from immunologic disorders throughout the body, including the kidney. It says immune complexes form as a result of immunologic reactions and increased serum antibodies, such as immunoglobulins. So when you read over all of these disease states, a lot of them are, first of all, they affect the glomerulus of the nephron, and a lot of them are caused, I want you to think about something. What is an immune complex? They're saying they're caused by immune complex. What 2 things do you have to have for an immune complex to form?
Antigen antibody.
Antigen antibody reactions, okay? So think of it this way. If you have something going on in the antibody that causes something going on in the body, all right, that causes an antigen and an antibody to react. I want you to think about like they're sifting through the bloodstream, and where they get caught up is in the glomerulus. Okay, they get caught up in there, and now because, kind of think it's big because you have an antigen antibody reaction, and because of that, it gets deposited on the membrane of the glomerulus and it won't go through. And a lot of times that causes like a little bit of scarring and stuff like that, and it just makes your glomerulus not work properly.
It's like
So immune complexes. Now when you're reading over some of these disorders, what are some things that happen that you hear about nowadays that people have that a disease state that is very, very common?
In regards to kidneys?
Autoantibodies. Autoantibodies, right? In other words, the body's attacking itself, right? Okay. Well, guess what? Autoantibodies cause a lot of the problems that we're fixing that are in the reading. So if you have an autoantibody, you're in trouble because you have something going on in your body where your body does not recognize self. So you have these antigen antibody reactions, and then they get deposited on the wall of the glomerulus, and they cause complexes. Yeah.
It kind of makes me think of atherosclerosis, where something's getting caught on the inside of the blood vessel.
Yes. Yep. So it goes on to talk about glomerulonephritis. It talks about acute post-streptococcal glomerulonephritis, rapidly progressive glomerulonephritis. There's something called Goodpasture syndrome, okay? But as you're reading over all of these, I want you to just think about antigen antibody complexes cause most of these things. Okay, nephrotic syndrome. This is the very last section on page 149. You guys have heard this term before. There is a question on the exam under this category, nephrotic syndrome. The first thing, the thing that every single question I've ever seen asked about nephrotic syndrome asks one thing, and it'll say, this condition has massive proteinuria in the urine. Lots of protein in the urine. It says that in the first sentence. It says the nephrotic syndrome is marked by massive proteinuria. It says there's also low levels of serum albumin, high levels of serum lipids, and pronounced edema. These people, because there's so much protein in the urine, there's not much protein in the blood. Does that make sense? Because it's all going through the kidneys. You're not supposed to have protein in your urine. But in this condition, called nephrotic syndrome, you will see an abnormal amount of protein in the urine, all right? These patients also will have edema. What is edema? What does a patient look like that has edema?
They're swollen.
They're swollen up. If you're losing all of your protein, what happens is your body starts retaining fluids. And those are the people that, like, if you look around their ankles, or even when you're drawing blood from them, when you press down, it's like
pitting.
like a sponge that doesn't come back.
And so most of the time you don't get blood, you get fluid. If it's bad enough.
Exactly, so make sure that you read over nephrotic syndrome. Then it goes on to talk about tubular disorders on page 150. Lots of different conditions that involve the tubules. We're talking about the nephron, the tubules of the nephron. Okay. All right. There's one that definitely sticks out that I have seen questions asked before. There's a condition on page 153 called Fanconi syndrome. Have any of you ever heard of that condition before, called Fanconi syndrome?
No.
I'm on page 153 in the left-hand column.
You talked about.
It says the disorder most frequently associated with tubular dysfunction is called Fanconi syndrome. So far we've said glomerular dysfunctions a lot of times involve immune complexes. Fanconi syndrome or tubular dysfunctions, all right, are going to be problems that consist of a generalized failure of tubular reabsorption in the proximal convoluted tubule. All right, so we move past the glomerulus. We're at the proximal convoluted tubule, where I told you guys you have this magical process that occurs known as reabsorption, where things that have passed through the glomerulus, the first part of the tubule, have to get back in the bloodstream. What's the one thing that I probably spent 30 minutes telling you guys about that you have to get out of that tubule and back into the bloodstream?
Bicarbonate?
That's one, but that ain't the one I'm talking about. But yes, that is an important one.
Water?
Since he just said bicarbonate, what's bicarbonate have to do with?
Buffer.
Buffers the blood, right? So you can't lose all that out of the urine, all right? And you might lose some as a compensation mechanism for acid-base disorders, but what's that other thing that I told you that you have to get back in the blood?
Glucose?
Glucose,
Okay.
bingo, glucose. This is one of the few conditions, Fanconi syndrome. If you have a patient that has Fanconi syndrome, that mechanism is not working that's taking things from that proximal convoluted tubule and taking them to the bloodstream. This is one of the few conditions to where you can see glucose in the urine, but this patient is not necessarily a diabetic.
Okay.
Remember I told you a regular person has a regular amount of glucose that goes through the glomerulus and the body's able to absorb it, to reabsorb it back into the blood. These people, even though it's a regular amount of glucose, it's not overriding the system, and the glucose will still be seen in the urine, but this patient does not actually have diabetes mellitus. All right. Now, where that's at, if you'll go on in the section that we're under Fanconi syndrome, go down to the very last paragraph under that section. It says urinalysis findings include glycosuria, that's just glucose in the urine, with a normal blood glucose and possible mild proteinuria. Urinary pH can be very low due to the failure to reabsorb bicarbonate. All right. You guys ever heard of diabetic nephropathy? Remember, we've been talking about diabetes. Why do they worry about diabetes? They're always concerned about a condition called diabetic nephropathy. It's kind of like long-term problems that diabetics may have. I'm in the right-hand column on page 153. It says diabetic nephropathy is currently the most common cause of end-stage renal disease. About 7 lines down from that, it says this glomerular damage is believed to be associated with the depositation of glycosylated proteins resulting from poorly controlled blood glucose levels. The vascular structure of the glomerulus also develops sclerosis. Next paragraph says early monitoring of people diagnosed with diabetes for the presence of microalbuminuria is important to detect the onset of diabetic nephropathy. remember how we talked about people that have diabetes, you want to start detecting protein in the urine as early as possible so you can detect early kidney damage. It's still not good, but you want, as soon as you start seeing protein in the urine, the doctor can sometimes maybe convince that patient, hey, you have really, really gotta start watching what you eat, okay? Because it's starting to affect your kidneys at this point. See, right now is when the patient truly has to start listening and doing the right thing, because after this happens, you know, eventually those patients can end up having to be on dialysis. That makes sense to everybody? So think of it that way if it helps you to remember it. I know a lot of this stuff is dry and you can only read so much if you're like me before you're just like, God, this has got to get interesting somehow. So maybe that helps you to make it interesting if you apply it to yourself. If you ever unfortunately get type 2 diabetes, all right, and you go to your doctor and they say, look, we're starting to see microalbumin in your urine, so you didn't listen to me last time when I told you to stop eating all those carbohydrates and all of that. Like, I'm telling you, you're starting to have kidney damage, okay? So a lot of patients, that's what it takes, and then you start seeing them control their diet a little bit better, okay? Acute pyelonephritis on page 155. Page 155, left-hand column. I don't expect you guys to remember it, but I told you guys something about, first of all, somebody tell me what pyelonephritis is. Anybody have any idea?
It's not pus in the kidney.
It's an infection.
It's what?
It's an infection.
Okay. You got two types of infections. You can have an infection of your bladder, which is called cystitis, or you can have an upper urinary tract infection, which starts getting toward your kidneys.
Oh, so
right?
it's in your
A
ureters?
lower urinary tract infection is called cystitis. That's what most people get. You have a urinary tract infection in your bladder, okay? An upper urinary tract infection, where that infection starts moving up, like up the tubules toward the kidneys, that's called pyelonephritis, all right? One of the things that I want you to remember about pyelonephritis, because they just seem to always want to know this, is in pyelonephritis, a lot of times you will see white blood cell cast in the urine, okay? You'll see a cast. We all know what a cast looks like, right? And you'll see some white blood cells in the cast. Is it common? No, it's not common, but they seem to always ask that. And where that's at in your reading, if you want to highlight it, I'm under acute pyelonephritis. Go down to the last paragraph. It says urine results are similar to those seen in cystitis, including numerous leukocytes and bacteria with mild proteinuria and hematuria. The additional finding of white blood cell cast signifying infection within the tubules is of primary diagnostic value for both acute and chronic pyelonephritis.
Don't you only get this for letting a urinary tract infection get out of control?
Say that again, Cash.
Don't you only end up with this if you end up letting a urinary tract infection get out of control?
Yes. Generally, that's why they want to treat urinary tract infections, is because that's one of the things they're always worried about. They don't want that infection to start traveling upward.
Yeah,
okay?
my brother actually got this one. Somehow, for whatever stupid reason, he let his he didn't realize he had a urinary tract infection, and he just let it go until it got to this point. It didn't get to his kidneys, but it was in his ureters. So.
Yeah. A regular urinary tract infection is not probably going to kill anybody, but it's, if you let it go, it's like you don't want that infection to start going upward. That's why you always need to have good urine flow. If you don't have money to go to the doctor, you know what I would do if I got a urinary tract infection? What should you do if you get a urinary tract infection?
Cranberry juice, drinking
Okay, you don't got no
loads of
cranberry juice
fluid,
either.
just water.
Yes, flush that out. Drink lots of water. I'm not, now you can overdose on water, okay? I don't know if y'all know that, but you can.
Waterlogged.
That's if
So
you
the
drink
radio
like
station
2
got in trouble
gallons.
for that one time. I don't know if y'all remember, they were having a contest to see who could drink the most water. And somebody got real sick because of it. The radio station got sued.
Yeah, because it makes your cells explode.
Yeah, never mind the fact that the person.
Anyway, but if you get a urinary tract infection, I don't want you suing me. But I want you to think about if you will flush your system out, void lots of urine, try to get that out, okay? But the problem is you have some patients that are really, really sick and maybe their kidneys aren't working. Those are the candidates that you have to worry about getting it backing up and going up into the kidneys and then pyelonephritis.
No, my brother's just an idiot. Because he had a government
Okay, under
insurance.
renal failure in the right-hand column on page 155, I want you guys to read about that. Guys, renal failure, I mean, that's like the worst, okay? You have kidney failure. Now, what you don't want to get is what they call chronic renal failure. That means it has progressed to where you get to kidney failure. There's some types of kidney failure where you can bounce back from it, okay? And you can have a complete recovery. I'll give you an example. Somebody gets in a car wreck and they have, they get squished in the wreck and they have a bunch of muscle damage. It's a real bad wreck, okay? Remember what I told you comes from muscle damage? There's that toxic substance to the tubule called myoglobin, all right? And myoglobin is toxic to your tubules. You can actually go into acute renal failure because basically your kidneys are poisoned real quick. You see what I mean? All that myoglobin hits it at one time. That's one thing they have to worry about. You have somebody that's been in a horrible car wreck and they're in the ICU, they are worried about their kidneys shutting down, okay? Because all that myoglobin from that muscle damage is hitting the kidneys at one time, and they could go into renal failure, but it's not that their kidneys are that bad, it's something that happened quick. So if they can fix that, okay, and they can help the patient recover, then their kidneys actually will start working again. Now, somebody that has chronic renal failure, like let's just say a type 1 diabetic that didn't watch their diet, you know what I mean? And it gets to that point, a lot of times that's not reversible. Okay. Okay, on page 157, under renal lithiasis, this has to do with people that develop renal calculi or kidney stones. The very first sentence under renal lithiasis says renal calculi may form in the calyces and pelvis of the kidney, the ureters, and the bladder. You've got a word there called lithotripsy. That's down further in the paragraph. It says this is a procedure using high energy shock waves and it can be used to break stones apart in the upper urinary tract into pieces that can then be passed into urine. Unfortunately, sometimes these stones have to be removed surgically. Right-hand column on page 157, go down to the second line in the right-hand column. It says approximately 75% of the renal calculi are composed of calcium oxalate. Okay, now it's got some other things, but I want you to remember that word. Calcium oxalate composes most of the renal calculi. Toward the end of that paragraph, I'm about 4 lines up from the very last part of that paragraph. It says patient management techniques include maintaining the urine at a pH incompatible with the crystallization of whatever chemical makes up that stone, maintaining adequate hydration to lower chemical concentration, and suggesting possible dietary restrictions. A lot of times with renal calculi, they want you drinking lots of water also. Okay, so why are we worried about that as techs working in the laboratory? Like, what's so big about renal calculi? Patients come in, what role do we have in helping a patient that has a kidney stone?
We'll see the calcium oxalate.
That's one of them, but I want you to look at the last 3 sentences on the last sentence on page 157.
Hematuria.
It says the presence of microscopic hematuria resulting from irritation to the tissue by the moving calculus is the primary urinalysis finding. So even though you may be working in urinalysis, doing all these urines, thinking how really significant am I, okay? If you have a patient come to the ER and they're having severe pain in their lower back, all right, one thing that doctor is looking for is a lot of times in these patients, there will be red blood cells seen in the urine sediment, but it's not gonna be like greater than 100, okay, or TNTC, too numerous to count. It's gonna be just a little bit more than normal, like maybe 5 to 10 per high power field. Okay, so even though you report that out and you think it's no big deal, that might be the deciding factor that ER physician, he or she needs in order to diagnose that patient with a kidney stone. Now, they also have imaging techniques and all that, okay, so you're not the only person that is giving out results pointing to that direction. But it's like a big puzzle. First of all, they're looking at the symptoms of the patient, right? That's pointing them that direction. They're probably gonna take some pictures, and then they possibly can see the stones. But that is just confirming it if the lab sends back, hey, we got a few more red blood cells in the urine than normal, okay? Now, there's some people that have a kidney stone that's so bad, when you get the urine down in the lab, you're not talking about just a few more red cells. Their urine will literally look like blood. I've seen that happen before too.
Yeah. Happened to my boyfriend's dad. He didn't even know he had a. Because he didn't have any pain or anything. Also, he just peed blood one day after he drank some beer the night before. He was okay. They just gave him some
All right, on
antibiotics.
page 158.
So he didn't have any pain.
You definitely would want to know the answer to number 1. You want to know the answer to number 11? Number 19? Number 20? And number 15? You guys probably don't realize it, but just trust me when I tell you, you're the first class that ever got off this easy on this chapter. Because I normally have went through every single section on that. But I came to the realization that I'm more interested in lab as far as you dipping urines and knowing how to look at a microscope and stuff like that than being able to tell me significant things about Wegener's granulomatosis, okay? So anyway, I just pulled out the important stuff.